Good afternoon. I am Dr. Mohamed Shakil. I am going to present a case of bilateral abducens palsy in a herpes zoster. A 17-year-old female came with complaints of fever for 4 days and complaints of headache and double vision in primary gaze. Headache was associated with vomiting and neck pain. 3 days later, she had developed vesicular skin rashes on right side of the face and neck with excoriation. Her past history of chickenpox 3 years back, and general examination, her blood pressure and pulse rate was within normal limit. Her body temperature was elevated. In systemic examination was unremarkable, and local examination, few grouped vesicle present over the right side of neck adjacent to the midline above the suprasternal notch. And move on to ocular examination. Head posture was erect and facial symmetry was symmetrical, and ocular position was orthophoric. In extraocular movement, there is a restriction in the abduction in the laterally. So visual acuity was normal, color vision was normal, and IOP within normal limit. In both a anterior segment examination on slit lamp was within normal limit, and diplopia chart was not reliable for here. And there is fundus examination was within normal limit, and this is move on to workup. There is inflammatory markers such as CRP and ESR was elevated, and in CSF finding there is a opening pressure of 70 centimeter which is elevated, and WBC count was elevated. Adenosine deaminase was elevated. CPNAT was done, and there is mycobacterium tuberculosis was not detected. And CT brain and MRI brain with contrast was done. There is no significant abnormality was found. Then as a move on to the diagnosis, as patient had the right side of mandibular region and neck. The diagnosis of herpes zoster infection involving the mandibular branch of trigeminal nerve and C2 C3 dermatome was made by the dermatologist. Then on the view of neurologist, there is a fever, headache, and herpes zoster infection in the history was found, and there is inflammatory markers was elevated. In CSF, there is elevated opening pressure and lymphocyte predominance, and increased WBC count was here made a diagnosis as herpes zoster meningoencephalitis was made. Then since we were not able to explain the restricted ocular movement in this, we went and searched the literature. We found abducens palsy as a complication, as a rare complication of herpes zoster. So we suggested here a diagnosis of bilateral cranial nerve 6th palsy due to herpes zoster was made. Then on management, we started on injection acyclovir 850 mg IV TDS, and ceftriaxone 1000 mg IV TDS was given, and injection dexamethasone 4 mg IV OD was given, and supportive treatment as pantoprazole, acetazolamide, and naproxen was given. The skin lesions resolved within 2 weeks, and gradual improvement in ocular motility was noted over the following months. In 6th week of the follow-up, the patient presented with a complete recovery of cranial nerve 6 function with a minimal residual abduction deficit. On the conclusion, thorough workup including the imaging to rule out the other possible causes of cranial nerve palsy, and the underlying pathophysiology of abducens nerve in the patients with herpes zoster is not well established, but could be due to the myositis or neuritis, and among other possible causes we should rule out. The benefit of antiviral medications and corticosteroid in treating oculomotor palsy remains debatable, especially in light of reports of spontaneous recovery. In addition, there is a early diagnosis allows prompt treatment and close follow-up. The suppressing viral proliferation in early stage of disease will make the patient to improve as much as possible. So here these are my references, and thank you.